Thank you.
Good morning. Very happy to join you. I'm so proud of Ohio right now, where we really are standing out as an innovator in healthcare and health policy. Not always the case for Ohio, but over the past couple of years, there has been so much going on, and this idea that now is the time to be in this business, because as intimidating as it can be with all the change that's on the horizon, there's an opportunity to grab a hold of that in a way that really lets us improve. I appreciated the reference back to the House Budget Committee. That was in 1991, and one of those first assignments for me was a bill called Administrative Simplification. It was taking the work group for electronic data interchange work and trying to create standards to go electronic in healthcare. And we tried to do that in 92 and it didn't work, and in 94 and it didn't work, but it was finally enacted in the Health Insurance Portability Bill, HIPAA, which is then how HIPAA became kind of associated with this idea of electronic communication in healthcare and privacy. Back then in 96, we were sure that within a couple of years, we would be moving healthcare information like the ATM card or your Starbucks card. And I'm just so glad that now there really does seem to be traction to get the tools we've needed for a while to really start working with delivery system change and workforce demands in a way that accomplish the triple aim. That's the starting point for us too. We need really better health outcomes for individuals. That's the key. We need to do that through better systems of care that are managing and keeping costs sustainable for everyone. So what I thought I would do is talk a little bit about, at the state level, what we're doing to try to help move in that direction. I think if we share what we're doing, we can see where the points of commonality and alignment are in a way that we can just keep course correcting toward what our objective is. We have a lot underway, so I'll start moving through that. Where I want to start is with a real sense of urgency about how quickly we need to act. What you're looking at, this is kind of a complicated chart. On our website, this presentation is available to you. So a couple of these slides you may want to go back to and use. This one I think is particularly interesting. What you're looking at is per person spending on healthcare by state, and the red bar is Ohio. So for us, we spend more for healthcare than residents of all but 17 states. So we pay on the high end. The position of the red bar left to right is in order of health outcomes. 36 states have a healthier population than Ohio. So we pay on the high end and we get outcomes toward the low end. That is the value combination we need to pay attention to. How do we stabilize or hold costs steady and improve quality? That is what we set as our focal point for thinking through state policy. Now, when you get down into that, what's driving the cost? Everybody has seen a version of this chart before. A very few of us account for most healthcare spending. About 5% account for half of all healthcare spending. Now, for politicians, this picture terrifies them because that 5% are the complicated folks who you don't want to be too prescriptive with. They're seniors, they're people with disabilities. So the tendency in health policy is to do these tweaks that affect everybody, but you're really missing the real issue, which is there are a few people who are very expensive. Often the system itself has created the breakdown where an otherwise preventable case of something was missed, dropped, there was a transition that was missed, and that person became unnecessarily complicated. Fragmentation in the system, which we work under today, is often the culprit that results in an unexpected or unnecessary outcome that makes it worse for the individual and is very costly to whoever's paying for care. Now, there's a lot in this fragmentation. We have multiple separated providers, reimbursement rewards volume, lack of comparison data, on and on and on. A paper-based system has always been kind of underlying this perpetuation of fragmentation. But we can see what works better when teams rally around the individual to meet the range of issues that person needs. There is an opportunity to provide better care. Our system has functioned to the left. We need to push our system to the right. So the combination of these two slides is what became our problem definition 2 years ago when Governor Kasich came into office. A few people have the greatest needs, and often they're expensive because the system has broken down around them. So if you flip that around, we prioritized small groups for whom better coordination can improve their health and save taxpayer dollars. And everything we've done over the past 2 years, one way or another, tracks back to that objective. The centerpiece was to turn that into a constructive statement, a vision of what we wanted our programs to work toward. And this matches the vision statement, I think, of many of the organizations you represent in this room. It's this idea that we need to organize care around individuals, regardless of what's convenient for the provider or for the payer, not system convenience, but what is it that we can do for individuals to meet their needs. Services should be integrated around physical health care, behavioral health care, long-term care, and social needs. We compartmentalize these things today. We pay for them separately. We have organized government to separate those things. We have a Department of Aging, a Department of Mental Health, a Department of Medicaid. My job was an insight on the governor's part that we need to organize across those units. So the Office of Health Transformation has authority to do strategic planning and budgeting across all of those agencies. So it's our version of trying to get a handle on how to get those systems to coordinate. Exactly what's going on in hospital systems or through primary care. How do you get those other people, other folks you depend on to get it right, organized and working together? Services provided in the setting of choice, easy to navigate, transition seamlessly, all elements of the vision we've laid out. Now, here, and I know at some point this will revert back to a picture of me instead of the slide, but if I could ask that we just leave this one up for a second. I know this is hard to see from the back. This is our strategic plan at the state level. Everything we're doing tracks back to this chart, and I wanted to spend just a minute to walk through how we've approached health transformation. The starting point for us was that when the governor came into office, we had a $7 billion budget deficit, a structural shortfall. Medicaid is 30% of the state's budget. So we knew we had to act first to stabilize the Medicaid program. We did not want to do that just by cutting rates on providers, although we did do some of that, or eliminating optional benefits, which often has this effect of eliminating preventive things, even though entitlements to things like nursing facilities are built into the law. We tried to preserve optional benefits and really look at delivery system change as the opportunity to build a more sustainable program. So we went back to that vision statement, where are a few people who are very expensive, and we focused on changing the program there first. We applied for and were one of the first states to get a Medicare, Medicaid integrated delivery care model approved by the federal government. So now all of the Medicare benefits and all of the Medicaid benefits will be put together as a single benefit through a care coordination entity. So that idea of rallying around the individual to make sure all aspects of care are available to them. We rebid our managed care system to be more efficient. We're creating health homes for people with severe mental illness. So this list of things in modernizing Medicaid are all oriented around, for the Medicaid program, improving coordination across all settings of care. That we initiated in 2011. Many of these programs are now rolling out. Many of you are participating in that process. So here in this area, we just need to stay focused on bringing those changes online. I'll take a quick aside to say that one thing that was on that list in modernizing Medicaid was this idea of, do we expand Medicaid to cover more people or not? I don't want to lose any opportunity to reinforce that the governor supports expanding Medicaid. He sees it as a matter of justice. And what you're looking at in this picture is how access to support for health coverage is going to change in January. In January, Ohioans with income between 100% and 400% of poverty, that's what you're looking at in the yellow range there, from 100% to 400% of poverty, will have access to tax credits to purchase health insurance through the health insurance exchange. People at very low income levels will have access to Medicaid, but only if they're a child or a parent. So in this picture, that third area under the dotted line are childless adults who under no circumstance will have access to Ohio's Medicaid program. Now, that coverage gap is about, we think, if we expand coverage, about 366,000 Ohioans would receive coverage who are currently in that gap. For the governor, it's a matter of justice. People at higher income levels are receiving assistance to purchase coverage as we're leaving a gap for the lowest income folks to not have access to support. I did want to just quickly mention who's in that group. There is in our legislature, I think, a perception of who the very low-income childless adults are. It does not match reality. Most of the folks in that group work. Many of them work as healthcare providers themselves. The person they are serving has health insurance. They do not, because they do not work enough hours, and wages can be very low, particularly in home health care. 26,000 of those individuals are veterans. This group does not get free care today. Because they're not connected to a regular source of coverage, they often end up in the emergency room where that cost is passed along either as a shift to folks who are paying or as uncompensated care that then the federal government pays a portion of that, but that amount is scheduled to go down in the near future. So it's not as if this group is free today, we're paying, it's just we're paying inefficiently. And we believe that getting a regular source of coverage through Medicaid is the answer to fixing that. This is going to become, thank you, John. This is going to heat up the next couple weeks as the legislature continues to say they intend to consider expansion in the context of the budget. We will see if that occurs by June 30. If it does not, I would expect the governor to take action after that to see what we can do to continue to pursue expansion. So modernize Medicaid, a lot of work in this first couple of years. This second column, and maybe the way to think about this, this is my viewpoint for the state of Ohio, but really this kind of a strategic plan is what many of you are dealing with in your organizations, where that first column is programmatic, the things you do and do you change how and what it is you do. This second column is really infrastructure. You all have a version of infrastructure that is, it's good, it's bad, it's old, it needs to be updated, wherever you are. For us, ours was very old. We have an eligibility system, for example, that is 35 years old. When a person comes in to see if they're eligible for our income-tested programs, 60% of the time, the computer gives the wrong answer. So the county caseworker has to override the computer to get the person either eligible or to tell them they're not eligible because the computer makes the mistake both directions. That is not something you can just upgrade. You have to swap it out. So we're in the process right now of rebuilding our eligibility system. But this point about not doing technology just for technology's sake, it creates an opportunity to rethink how we do this work. Do we really need to send every family member down to the county JFS office to sit through a long process to see if they're eligible for a program or not, when really online you could just check their income, and if they're below a certain income level, they're eligible for the program. So we have an opportunity here to change how we do business to orient convenience around the consumer, not just supporting kind of the government systems we have allowed to develop over time. So that issue I have huge hope for in terms of being able to improve how we do business. There are other things in this category. Our Medicaid department was down as a division buried in a department, even though it's a third of the state budget. So on July 1, we're creating Medicaid as a standalone department. We had mental health and addiction service organized as two separate departments. We thought that was working against us in being able to integrate services. So on July 1, those two departments are going to be consolidated. So there is a lot of work underway, but I consider it kind of our own internal house cleaning. But hopefully it puts us in a position then to be better partners as we start looking at this third column. How do we pay for value? Here, the real question, I think, is how does the state of Ohio leverage its purchasing power to bring other purchasers of health care together around a table to say, how do we improve our expectations for what we get? Because back to that first chart, we're paying a lot and we're getting poor outcomes overall, in general. Why do we allow that? Why are we spending our money that way? Now, part of the frustration is any individual organization that tries to take that on doesn't have the market power to move the system. But Medicaid and 5 insurance companies cover 90% of all the lives in Ohio. So what if those organizations got together and said, you know what, if we all pay for patient-centered medical homes differently, it's very hard at the practice level for people to make the commitment to convert. Am I converting to the Anthem version, or am I reporting to Medicaid? But what if all those payers said, we are going to have a uniform payment policy to reward practices that convert to patient-centered medical homes? Overnight, that could leverage interest across the board for people taking that step. So that's how we're thinking about not micromanaging the delivery system level, but more like a business thinks about it. I am going to hire an agent, an insurance company, to create a network to achieve certain results. What are my expectations for how that works? We have an interest in a system that generates value without ourselves needing to micromanage what happens at the delivery system level. So as we move into that column of paying for value, we did early on, just as a signal that we wanted to move in this direction, join something called Catalyst for Payment Reform. About a decade ago, this was called Leapfrog, and a lot of the leadership who created Leapfrog is now a part of Catalyst for Payment Reform, bringing together GE, Procter & Gamble, Intel, very large businesses to say, where is our common ground expecting better results? We were the first state Medicaid program to join what was otherwise a private sector initiative because they wanted us because we have tremendous purchasing power. We wanted them because we're viewing ourselves as a purchaser, not a micromanager of the delivery system. Now, sometimes timing just works to your advantage. It took us a couple years to look at modernizing Medicaid and streamlining health and human services. But this year, as we were last fall starting to think about how to move into this territory of rewarding value, paying for value, the federal government, through the Centers of Medicare and Medicaid Innovation, had a competition for states that wanted to innovate in payment. We applied for that, and we won a design grant for payment innovation. So that has now shaped and created an opportunity to not only at the state level, but with Medicare participation, take on payment innovation. We have a governor's council that is representative of health systems, health plans, providers, advocates that are helping us shape this. We see our role as convening not just public service, but public and private health sector interests to coordinate multi-payer healthcare payment innovation activities statewide. The State Innovation Model Grant was encouraging states to focus on either financially rewarding patient-centered medical homes or converting acute care into episode-based payments or build accountable care organizations. Those were kind of the three tracks. Now, other places may have a handle on accountable care organizations, but here in Ohio, I think we're not quite ready for that. And I think the reason is everyone sort of sees themselves being that without understanding what's really required underneath to pull it off. So hospital systems are saying, well, just cut out insurance because we can be the accountable care organization. But when you talk about what it means to take on risk, they get a little nervous about that. Managed care companies are saying, well, accountable care organization is just another name for managed care. Just give that to us and we'll organize the network to take care of. I think in reality, a few years down the road, accountable care organizations are going to be some blended organization that doesn't exist today, but that will have relationships that really can coordinate care and provide care at a clinical level to meet all of the needs of an individual. But until we get there, we wanted to start with things that we thought we were ready for. So we focused on There we go. So we focused on providing access to medical homes, and we're setting a very aggressive goal here, that every person in Ohio has access to a medical home in the next 5 to 7 years. And for episodes, we are looking at prioritizing initially a group of 3 or 4 episodes, maternity, hip replacement, something where you can have a discrete set of services focused on something where you can measure performance as an outcome and pay for that bundle in a way that encourages the entire team that's required to pull that off to work together. Arkansas is a state that has been very aggressive in this area. We hired the team in Arkansas to come to Ohio to help us do this. So we are now focused on trying to identify a group of episodes that we think we're ready to take on here. Those things start being the building blocks that you can build up into an accountable care organization. So we're very excited about that. When you start thinking, though, about what it takes to change how you pay, to reward performance, well, what is performance? What can you look at? You need more primary care. Do you have enough people trained in primary care to support a patient-centered medical home for every Ohioan? Suddenly, you're encountering these barriers to actually being able to move to a model that through payment is rewarding delivery system change. So that's why this last group of prioritizing state activities that enable payment innovation, this is what really connects directly into your day today. We want to use our state innovation model grant process as an opportunity over the next 3 or 4 months to design not only a specific payment strategy around patient-centered medical home and episode-based payments, but also to start laying out what would be a statewide, state-initiated strategy around health sector workforce development, HIE infrastructure, and performance measurement. Now, much of that work is already underway, and I'm not talking about duplicating or undoing what's already out there, but it's a matter of taking inventory of the tremendous resources we already have available to us and start aligning that toward things that support rewarding value instead of rewarding volume in how we provide care. So knowing that we are going to be starting to develop a strategic plan, conversations like the one you're having today is extremely important, because over the next 3 or 4 months, we're going to be looking for ways to tap into your thinking to understand how we can support that through a state-level workforce, HIT, and performance measurement strategy. So this is our team. We did a lot on modernizing Medicaid. We've now handed that off to the Medicaid director. We did a lot related to getting our infrastructure lined up, but that now has been handed off to the different directors who are doing that work. we're putting the entire focus of the Governor's Office of Health Transformation on payment innovation over the next 2 years. So it's our highest priority. As we do that, there are a lot of regional payment innovation activities already underway. Northeast Ohio has been very aggressive. Southwest Ohio has a patient-centered medical home pilot endorsed by the federal government underway. We're looking to those to provide answers of the direction we should take as a state. Where things are working, how can we accelerate that and push it along? Okay, there's a lot there, but again, my purpose is in laying out what we're working on and thinking about. Hopefully you see some commonality with some of your priorities, because we've really tried to listen to where folks think we need to go and come into alignment with that. So as you talk through these issues today, think about how you want to communicate back to me. On that website I mentioned, actually I think I have it here. On our website, my contact information is on there. So if some of you are interested in this process, we are going to have to organize how we keep that a manageable process. But I always welcome hearing from folks to identify where you think the really good work in workforce, HIT infrastructure, and performance measurement is, and we'll just tap into that. Okay, thanks for the time today. I appreciate being here. Enjoy the rest of your day.
If I can have my mic open. Yeah, we have some microphones in the center of the room that you can ask a question of Greg, and he'd be happy to take a few questions.
First, Mr. Moody, as a family physician, I appreciate your comments, and as someone who takes care of the working poor, I appreciate your comments on Medicaid expansion. My question is around how likely do you think it is that you'll get insurance companies to work together to do payment innovation in terms of reimbursing practices for patient-centered medical home transformation?
I have the same question myself. The initial conversations have been very good. We started January 9 with a meeting where we had the CEO of the 5 largest plans in Ohio in a room with the governor. And the governor saying to them, it's our expectation that to keep Ohio competitive, we work together to build out some of these common models. And we received a commitment from all 5 of them, and not the big CEO in some case, but the regional CEO, in all cases to work together. Those 5 have tremendous reach here in Ohio in terms of the number of lives they cover. Now, these things always complicate then as you get down into the detail where, well, we were all for this, but now that I understand I have to do this, I have some concerns. So that's where we really reached out to a group that had done this already. And we ended up, through a competitive process, we hired McKinsey to basically be our team managing this process. They managed this process for the state of Arkansas and were able to actually come up with some specific episodes and payment for patient-centered medical home that are going into effect there. Now, they have one dominant payer, so it's much easier to get that dominant payer and everybody else has to come along. It's what I think is going to make Ohio very interesting to the federal government. If we're able to bring along multiple payers in a state with a very large population, I think that's going to be interesting for Medicare to sit at the table with us to see what we can do. I think it has huge potential. So I'm optimistic. The initial conversations have been very good, but it's going to get only more difficult over the next couple weeks.
Morning, Neil Dawson from the Center for Healthcare Research and Policy. You mentioned bundled payments, and the examples you gave basically had to do with episodes of care around some procedure. How are you thinking about these payments relative to chronic care and prevention that don't fit neatly into our usual model of a single episode of care, but clearly are very important for the long-term health of folks in Ohio.
Yeah, I wish we had 2 hours on payment innovation, because how you sort it all through is really complicated, and we're just trying to learn ourselves. Today, if you think about it, if you look at how we pay, it's almost all fee-for-service, with then some population health around, for example, some plans that give enhanced payments related to being a patient-centered medical home. But it's all this fee-for-service with a little bit of what I would say population health-oriented focus. What we want to do is change what that mix looks like. In between there, about 60 to 70% of all Ohio healthcare spending is on about 15 acute episodes that are fairly discrete that you can identify. So if you start there and say, what are 1 or 2 or 3, that if we start bundling that and looking for performance there, you're having a big effect in terms of getting at the spend. So the idea is pushing out fee-for-service, moving to bundling for things that are kind of acute episodic events, but at the same time, focusing on performance-based payment around population health through things like patient-centered medical homes. It is not one or the other. It has to be a series of things that mutually reinforce. Now, some of those episodes could be, for example, around behavioral health, and it gets much more complicated very fast. One of the criteria we've set for ourselves is to pick an episode that's really easy and to pick an episode that's really hard, just so we can start to learn if we have this is where infrastructure becomes important, if we even have the capability to knit together what the team would look like that's required to provide the episode. So it's a work in progress, but I would encourage you particularly to look at how Arkansas made the choices about what they picked, because, for example, behavioral health was one of the episodes they selected. Another question? I really do appreciate the affirmation on expansion, by the way. Thank you for that. John Corlett, I think, started the clapping over here. Yeah.
Mr. Moody, good morning. Thank you for your comments today. I think we all support the concept of expanding Medicaid and providing for those who need the care. And we appreciate your approach to the economics of this. I'm Ron Savin, the director of the Medicare QIO for the state of Ohio. And so I'd ask you, what's going to be the state's approach to doing the same sort of alignment with the quality factors? You mentioned how important it is to get all of the insurance companies to move together on payment reform. But I think we need to do the same kind of thing with respect to Medicare, Medicaid, and the commercial players in terms of quality, so that we get the diabetic foot looked at, and so we don't have automatic mammography on 88-year-olds. What's our approach to that, sir?
Yeah, absolutely. I think our thinking, my personal thinking on this has changed quite a bit over the 2 years of working with the governor on this, where originally I had this idea that you have to build from the bottom up to make sure you have the pieces in place to then take the next step. And I think a lot of healthcare has worked that way, where, well, wait a second, we can't pay for quality yet because we first have to have a complete paradigm on quality to be completely sure what we know it is, so then we can attach payment to that. And that ends up being used, I think, by folks who benefit from the current fee-for-service system to just kind of avoid shifting to something that's maybe a little more challenging in terms of performance. So the reason we have put all of our focus on payment innovation is because I think it forces several important issues. Okay, so if we're now going to pay for a patient-centered medical home, are we going to pay exactly the same for everyone, or do we care if some are performing better than another? Well, clearly we would care. So now you have to be able to measure their performance. So now, because payment's at risk, you've really forced the issue of needing to be able to measure performance. And I think it's a way to kind of force people to the table, in a sense, on some issues that are easier just avoided or complicated to the point you just don't act. And the three areas we've identified there are HIT infrastructure, because now to get an additional payment related to be a patient-centered medical home, you have to have the infrastructure, and not only in place, but you have to show how you're using it. We have to be able to measure performance to do an episode payment, because one way you could save money in an episode is to just under-provide care. Well, that's not our objective of that. What we want is to pay for a positive outcome, and only in the case of a positive outcome that followed evidence-based standards do you then get access to the payment. Well, that requires a performance measurement framework. So we're really trying to understand how payment innovation becomes the lever to force a better understanding of quality measurement, infrastructure, and also workforce. Okay, now you're telling us we need patient-centered medical homes, but we don't have enough people to hire. Well, we need to take that on. One thing you may be interested, because your focus here is workforce today, even though we didn't feel ready to lay out what I would call a complete state-level workforce, health sector workforce strategy, we did want to send a clear signal we're serious about this. So in the budget that's pending in the legislature right now, we took all Medicaid direct medical education. It's $100 million a year, and we've put it on the line. And we said that not this next year, but beginning in 2015, we are going to reprioritize what teaching institutions receive direct medical education. We are less interested in subsidizing the training of cardiologists, for example, than we are in training primary care doctors or recruiting minorities into health professions, things that attach to a public purpose. That doesn't mean we don't want to help train specialists. There are some specialists in Ohio that we don't have enough of, and a matter of public policy, we want to support that. But this has the potential to shake things up a little bit. And, for example, why do we only pay for medical education within the hallways of a hospital? Shouldn't we be training people in sites that actually put them in the settings where we want people to be trained? So we're wanting to force that conversation by saying, we don't know what we're doing yet, but we're going to put $100 million on the line. We've already reached out to the deans of the medical colleges, and we have their commitment to work with us, but we don't see it as limited only to that group. We see this as being a much broader conversation we need to arrive at recommendations within a year, so then we're able to reprioritize that funding in the next year.
Thank you.
Yeah. Good, absolutely.
The Medicaid nursing home is sort of a separate problem and a big problem. What changes do you see in that?
Wow, could I tell a story on that one? You know, to understand Ohio, many of you, who have practiced here, lived here, probably have a sense of this, but many of you may not. For years in Ohio, nursing homes were paid according to a reimbursement formula that was guaranteed in statute to go up about 6% every year. So through the Medicaid program, as physician and hospital and other rates are held flat for years after year, decades in some cases, every year nursing facility spending was going up. It led to a situation where we are over-institutionalized in Ohio in a significant way. So for us, on that modernized Medicaid, one of our first priorities was around getting dollars out of that institutional setting into the home and community-based setting. And our first pass at that 2 years ago in the budget was to reduce nursing facility reimbursement rates about 6%. But even though we had a budget hole, we didn't use those savings to fill the hole. We put every single one of those dollars, plus about $200 million additional dollars, into building additional home and community-based service capacity. So that will stand regardless of how all this wraps up for the Kasich administration. I know that decision will stand as something he is most proud of in this space, that we were able to do that. Now that we've done that, it brings along some additional considerations. For example, home health is largely unregulated as a service. So if we're creating demand for home and community-based services, what obligation does the government then have to make sure that folks in that setting are safe and that workers in that area have the adequate resources they need to do a good job? That then forces that next round of issues. There are several things in this budget that address that. One last thing, just because I can't help myself. One of the most exciting things in this budget is because we had all those beds, and because at the same time our mental health system was being underfunded and resources were draining out of that system, we had a lot of Ohioans who what they needed was community mental health, and it was not available to them. But there was an empty nursing home bed. So that's where they ended up. We have thousands, no, I'm going to back off from that. We believe we have a challenge in this area. What we did in the last budget was create a specific diversion program where in a year and a half, we've moved 800 individuals already who were living in a nursing home, but what they needed was community mental health. We are stepping up that activity to move even more people out. It is just wrong to default to that setting for lack of providing, frankly, less money in a better setting. It's one of those great things you have in health policy where the thing the person needs and wants is less expensive than what the system has forced them to take. Think of that. You can save money and you have a person better served where they want to be. That is a home run for health policy. So it's an example of, by setting the problem definition the way we did, it took us straight to that issue, and we had the tools we needed to act on it. So I think it's a good example of what you can do with thoughtful public policy. Okay, you need to get on with your program. Thank you.